Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a shallow chamber angle closure glaucoma, actually had a dense cataract and a phacoemorphic component to his cataract. And so this is a continuous OVD infusion technique to flatten the anterior capsule for the capsulorhexis. You'll see I'm going to use a two-handed technique, and I'm pushing the viscoelastic through the paracentesis site as I do my capsulorhexis. So you can see this is the eye. This is actually a very shallow chamber. You'll see that the patient actually has posterior synechia, as you can see here, as well as a laser peripheral iridotomy, which was performed here. So I'm using a cotton tip to hold the eye, and then I'm using a corneal marker to help me center and size my rhexis. I'm steadying the eye with the cotton tip and making my paracentesis incision first on the right side and then the left side. This is the left eye of the patient, and you'll see that the patient has a little bit of a Bell's reflex, which will make it a little bit of a challenge during the surgery. So I'm injecting some intracameral lidocaine and then some intracameral epinephrine since the patient has a little bit of an irregular pupil. The intracameral epinephrine didn't really seem to do much. And then this is the intracameral dispersive viscoelastic to fill the anterior chamber and flatten the anterior capsule. This is the triplanar corneal incision. There was some oily material on the eye, so I asked the technician to flush the oily material. I make a vertical groove, place the blade into the deep part of the groove, controlling the eye with the cannula, flattening it out, tunneling through the cornea, turning the eye towards me with the cannula, and then entering. That's the triplanar corneal incision. And so this is the part that I'm talking about. And the patient does have a little bit of a Bell's reflex. I'm going in sideways for my puncture style rhexis. I'm injecting some viscoelastic as I go. I'm going to puncture the central capsule. And again, this is a very shallow chamber, and you can tell that the anterior capsule is bowing forward quite a bit. So I puncture, grab the right side of the tear, trying to very carefully go around. I'm injecting the viscoelastic as I go around because I know that it's going to try to radialize. So I'm pushing the viscoelastic, grabbing and re-grabbing, trying to make sure I'm not putting too much pressure on the wound and causing the viscoelastic to come out. Grabbing and re-grabbing, pushing the viscoelastic with the cannula simultaneously. Now, mind you, the patient did get a Hohn balloon, and so despite the Hohn balloon, there is this shallow chamber. I did not use any mannitol or Diamox or anything of that sort. So again, without using any mannitol, I think this is kind of a nice intraoperative technique. You can continuously push dispersive viscoelastic to flatten the anterior capsule while you're doing the rhexis. So this is the Capsulorhexis hydrodissection technique. I place a cannula out to the equator contra-incisionally under the rhexis edge, pointed tip down, getting a nice fluid wave there, decompressing on the left side, sweeping along the left side, and then turning the tip down. The lens came up out of the bag a little bit. So we're going to begin the phaco, irrigating the surface of the cornea first, lifting the incision with the chopper, going in with irrigation off to minimize Decimase trauma, removing the surface epinuclear material. At this point, the case should otherwise go routinely. The hardest part with these shallow chambers is really the rhexis. Place the chopper underneath the rhexis edge out to the equator, pointing the phaco tip vertically subincisionally, crushing the lens in half, bringing the instruments together. That's double chop. Placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing and bisecting the right heminucleus, that is the cross chop. Using a little bit of vacuum to lift that first quadrant up, and using mechanical fracturing forces to emulsify the lens piece. Placing the chopper around the second quadrant, pulling it up out of the bag, very gingerly here. I don't want to create too much zonular stress. Any patient who has angle closure attacks, those patients tend to have weak zonules, and so I think that also is exacerbated during the rhexis because of the weak zonules. I turn the second heminucleus in front of me, place the chopper around the lens piece completely, making sure I'm around the entire girth of the lens. It didn't really chop appropriately here, so I'm having to go back. And I could feel that the chopper was not quite around the entire girth of the lens there. So I tried it multiple times, and I finally did get around the lens. And mind you, because of the technique, I don't really have any fear that I'm on top of the capsule when I do this maneuver. Pulling the third quadrant up out of the bag, hooking it with the chopper, holding it with a little bit of vacuum, and then crushing it into smaller pieces and then emulsifying the lens piece. So very carefully turning that fourth quadrant in front of me, placing the chopper around it, placing the phaco tip deep in the bag, and then crushing it and bisecting it in half, and then using successive crushing forces to break the lens into smaller pieces between the chopper and the phaco tip. And then when the pieces are small enough, begin to start emulsifying the lens piece. So again, just under irrigation, I tease that last fragment up. I like to use that technique, just lifting pieces up out of the bag under irrigation only, instead of trying to go after it with high vacuum. So once the endonucleus is removed, I start to remove the epinucleus from the anterior portion first, and then it tumbles out very nicely here, placing the chopper in a deep position to protect the posterior capsule. I take the chopper out, push BSS in, take the phaco tip out, and then go in with the INA handpiece. Like I said, patients who have had angle closure attacks, they tend to have floppy irises. They also tend to have weak zonules. And so it's very, very important to make sure that you protect the capsule and as well as be aware of the weak zonules. And so I switched to polish mode very quickly here. And you can see, if you pay attention to the rhexis edge, this bag and the zonules are very unstable. So I'm going around polishing. Again, because of the weak zonules, it was a good idea to switch to polish mode instead of going to the Cortex mode, because I'm sure that I would have been able to pull on the capsular bag and on the zonules. So I don't know if you can appreciate that, but as I'm polishing, even under polish, which has very low vacuum and aspiration, you can see it's causing the Capsulorhexis opening to become distorted. It's not perfectly round. As I'm pulling it, it kind of wrinkles up. So I'm polishing the posterior capsule now, especially in the subincisional area. Yeah, you can just see that the bag is not really great. I'm not sure if I put in a 3-piece or a 1-piece lens. I might have put a 1-piece lens in this patient. Oh, I think I did, because I think the lens power is really, really high. Yeah, I think this patient has a 36 power lens. So once I'm done, I'm pulsing in a subincisional capsular fornix with the BSS cannula. You can see there's some material there that I'm pulsing. And it's a little bit stubborn, probably because the bag is floppy as well. So I'm injecting the cohesive viscoelastic to fill the capsular bag. I'm probably going to just polish and sweep to get the remainder of that subincisional material. So yeah, as I recall, this patient had a lens power of 36. So again, small eye, angle closure glaucoma, weak zonules because of the angle closure attack. And so this is really a setup for a lot of potential difficulties and complications because of this situation. Shallow chamber, higher risk for corneal damage, weak zonules, higher risk for posterior capsule rupture. So because this is a high-powered single-piece lens, I have to widen the incision. And then using the sweep to hold the eye, I'm very carefully placing the injector through the incision. I placed the leading haptic into the capsular bag with the trailing part out of the bag, going in quickly with the INA handpiece, activating irrigation, and then making sure that the trailing haptic goes into the bag. I'm having a little bit of chamber instability. It's probably because of the widening of the incision. I'm going underneath the lens and tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag. And then I switch back to polish mode because I see some mild cortical material. That's the advantage of having foot pedal control. I'm able to quickly switch to the different settings. So there's a little bit of cortical material in the subincisional that I was able to get with the visco mode. And so now I'm removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this was a patient who had a small eye, very shallow chamber, history of angle closure glaucoma, posterior synechiae. We performed a peripheral iridotomy, used a Honan balloon, but did not use mannitol, and I performed a continuous OVD infusion technique during capsulorhexis to continue to increase the intracameral pressure and encourage a flattening of the anterior capsule. By doing so, I was able to get pretty well-controlled capsulorhexis. Again, some patients can't tolerate the systemic Diamox or mannitol, and of course that adds time to the procedure preoperatively. And so I decided to try doing this technique, and it tended to work pretty well in this case of a patient with a small eye and a high-powered lens. Again, 36 diopter high-powered lens in this case. Again, I would have ideally picked a 3-piece lens because of the weak zonules, but because of the high-powered lens that I was needing to use, we had to use this single-piece acrylic lens. So I hope this was helpful to you, and I thank you for your attention.